Okay, good afternoon. This is Travis. I'm filling in for Jeff this week. So far, we've got a small crowd, but we're going to go ahead and start and see who else joins. So, Seth, you want to go?
Yeah, sure. Uh, so this is going to take forever to load. My computer's running real slow. Let's see how. Oh, that's not too bad. So this is a guy who um, came in with chest pain, shortness of breath, and had a CT and outside hospital that showed a large dissection. But what's interesting here is um, the surgeons asked us to scan him for various reasons because they wanted to figure out why he wasn't dead. And I'll show you in a second if this ever opens up. There we go. Come on. So not a good study in terms of quality. The guy was throwing PVCs like crazy. So one thing you'll notice is that he's got this type A dissection, and his LAD was what looks like his left main, but actually just turns out to be his LAD is completely knocked out from basically the dissection flap extending into the ostium of what should be the left main, but is in fact only LAD. And the reason why he's not really dead is basically he has separate origins of his LAD and his left circumflex, which is relatively uncommon. Cath literature says it's about 2%. I think it's a lot less than that. Personally, from reading a lot of CTs, coronary CTs, I don't see this very often. That's not a dissection flap, by the way. That is just the SA nodal branch. But it's just random that, in fact, the thing that saved this guy's life is that he has a relatively rare variant where he has no true left main. So he just knocked out his LAD. Again, the imaging isn't great, but you can see here that there's perfusion abnormality involving, if this will ever, involving that distribution. You can kind of see it here on my screen that's freezing. It's not going to want to play, but everyone, most of us know what this distribution will be. So in terms of motion, but you can see here very nicely that there is no motion in the LAD territory all the way around to the apex. This is all LAD territory. You can also notice that the myocardium is relatively hypoattenuated compared to the RCA territory inferiorly, which is pumping pretty good. So I thought that was pretty cool.
Hey, Seth, is he Marfan's or some sort of elastopathy? It looked like he kind of had that annuloaortic ectasia look. You know?
That's a good question. Not that I heard of that I know, but you are right. His aorta and his aortic root is quite dilated. And I was just shown this case yesterday or today, I think, or yesterday I was shown it very briefly. So I didn't look up his history, but you're right. His root is quite dilated, or at least it looks quite dilated. Yeah, it's dilated, and I agree. He might have some sort of cystic medial necrosis or annuloaortic ectasia, but I don't know if he's marfanoid or not.
I guess it's a moot point. That's a pretty interesting variant that he has that saved his life.
Yeah. This is. Oh crap. Okay. I wanted to email. So I got beautiful gross path on this case. This is a woman who came in from an outside hospital. I apologize. The scans aren't great because they're from an outside hospital, but comes in with this basically with tamponade, has this very large, ugly mass sitting what looks like to be in the pericardium, and is kind of squishing the right atrium, and also has all of these metastasis, very vascular metastasis. If you notice, there's a lot of vessels coursing through this lesion. Now, she had developed some form of, I'm not really sure, but it was some sort of immune reaction to one of the antibodies on red blood cells, so they couldn't transfuse her. They had to get like special packs of blood sent from some hospital out in the middle of nowhere that was specially designed. And they only had like 4 units in the country for her because she was basically hemorrhaging everywhere. They couldn't control her bleeding. They went into her chest just to try to get a piece of this thing, and they basically said cutting into it was like cutting into the ventricle itself. It just was hemorrhaging blood. They sewed her back up. She basically developed tamponade and died. And I went and helped out with the autopsy on her, and the heart and lungs were pretty impressive. The lungs were just, and I have pictures, I'll send them to you guys. The lungs were just covered in these very black red masses or nodules from the mets, and the heart was just a mass of blood, and the tumor wasn't that large. What was interesting about this angiosarc was that it didn't really have, it was totally pericardial. So most angiosarcs arise in the epicardium, in the epicardial fat. This one arose in the pericardium. He still calls it an angiosarc, classic angiosarc, but it really did not have an epicardial component, which was interesting. But anyways, the reason I downloaded this was to show the beautiful path imaging, which I forgot to, it's on my phone because I took pictures with my phone, but I forgot to send to myself. This is a cool case where I went down the tubes just from lack of history, which none of us had. So this is a guy who is youngish, never been diagnosed with anything, came in with a pathologic fracture of both femoral necks. You can see this guy's never been to a hospital. He's never been treated with anything. You can see his bones are not normal in any way. They got a chest CT, and the only history I had was pathologic femoral fractures. He's clearly a dialysis guy. He's got no kidneys, and he has all these mass. He's got bulky adenopathy. So I was thinking this was, I don't know, lymphoma, something that was, I know the bony lesions are a little atypical, but I just figured it'd be simple bony mets from something. And so they went ahead and biopsied these things. Oh, where's my, anyways, I'll show you, I have the PET. So the patient also they did a parathyroid level, and the patient's parathyroid level was like 50,000. And they did an ultrasound, which showed, which I'm not going to bother you with, which showed 4 dramatically enlarged parathyroid glands, and also did a SPEC study, which shows, if I can get it to work, just uptake everywhere in the region of the parathyroid. Again, these are not the best images. And so they biopsied these, and these lesions in the chest were all brown tumors. And I don't think I've ever seen it before. I mean, I know they occur. I just don't know. And you can see the bony disease, which is much, more of the kind of rugged Jersey spine than the typical stuff you see with just simple renal osteodystrophy. So this was a case of presumed really bad hyperparathyroidism, likely due to renal failure, although he had multiple adenomas in his parathyroid. These were all brown tumors. And
what was the cause of his renal disease? What's the kidney disease underlying this?
I don't know.
Okay.
He literally was like some homeless guy on the street, no history, and not clear what the cause of the renal disease is.
Got it.
Don't know if it's developed, it was developmental. I have no idea.
Okay.
But yeah, it's just I've not seen those before.
Spectacular. Can I ask you a question about your previous case of angiosarcoma?
Yeah.
When you see say epicardium, do you mean the visceral pericardium, or do you mean the outer muscle of the heart itself, myocardium?
No, I mean, there's debate about where these arise. When I talk about epicardium, I'm more kind of insinuating the epicardial fat, kind of deep to the pericardium. Okay. But within that fat, within that area that's outside between the myocardium and the pericardium, that's what I refer to. Okay. there are, when we talk about delayed enhancement, we use sub, epicardial, subendocardial and mid-myocardial. But when I use epicardium, it's predominantly all the cardiac structures that are deep to the pericardium but outside the myocardium.
Got it. Thank you.
If that makes any sense. And other people may have different, that's what I use to describe it. Okay, I showed that one. And then last, sorry, this would go, I can't remember what this case is. Oh, yes. Yeah, it's an interesting case. So this guy came in to the emergency room, fever, this and that, got an echocardiogram. Echocardiogram saw a mass in his heart, and they got a CT. And one of my fellows was looking at this, and I said, well, usually don't see air in a mass. This presumably is some form of endocarditis or vegetation. Well, it is endocarditis, some vegetation, because you usually don't see air within the structure. He also picked up, and you can't really see it as well here on this portion of the study, but I'll show it to you on, where is it? On the arterial phase, which is an abdominal phase. He also has a pulmonary embolus, which is interesting, and I'll show you why, because the pulmonary embolus, which you can see basically on the first image, also has air in it from this infected thrombus. We called up the team because we were like, this guy's got, vegetation. He's embolizing his vegetation. His vegetation has air in it, or his pulmonary emboli and vegetation have air in it. And they're like, yeah, we know. He's basically injecting. He has a central venous catheter, and he's injecting fecal material, his own fecal material, into the central venous catheter. We're not really sure why, but he decided to inject himself with his poo. And so this is a fecal embolus, or, well, it's not really a fecal embolus, but it's the bacteria infection from his embolus. And of course, in grand fashion of wasting money, they wanted an MRI to confirm that the mass-filled air in the guy injecting fecal material through a central venous catheter was not a true mass. So we got a MRI, which is obviously a complete waste of money, which showed the mass. And then if you really want to, I think the best way to delineate between a tumor and a thrombus is really to do your inversion times at very normal and very late using the magnitude images. And you can see at a magnitude image with a nulling point of 300 that this thing hasn't yet nulled, whereas it nulls out on the 600 at a much later inversion time. And I don't want to go into the physics of it, but you can see here on the shorter inversion time of 300, which delays myocardium, and should see delayed enhancement for anything that has some degree of gadolinium in it. It still hasn't nulled yet, but when you go later on at a much later time, you see it starts to null, and that's pretty characteristic of thrombus. We have a bunch of these cases and have been, pretty good accuracy diagnosing thrombus this way. So this was a thrombus / vegetation. But those are my cases.
That's amazing.
Wow.
Was he trying to commit suicide, or do they think it's Munchausen syndrome, or they don't?
They called it Munchausen by Poopsie.
Nice. All right, who wants to go next? I see Brent's on here now too, in addition to David and Howard.
I can show cases anytime.
Okay.
Okay. Let's see. This one is kind of a cautionary tale, so it's interesting by virtue of how things evolved. So I'll tell you just to start off that this was done because of chest pain, sudden onset of severe chest pain. And this was done at a hospital, and I could tell from the outside exam that this was done for PE. So we have a CTPA, the contrast mediums in the pulmonary arteries. Now, I'll scroll through there. I can't quite tell what happened here, why it's flashing like that, whether there's some series that have merged in some way. I can't quite figure that out. But let me just stop there with the contrast medium in the pulmonary artery, and I'll tell you that no acute PE is present, but there is a finding here. I'll just give you a moment to look at that. That turns out to be relevant, which I'll show you a bit more in a moment. But about here, particularly about, yeah, that image there is a finding related to the pulmonary artery. That's interesting. So I guess that they diagnosed no PE, and I presume they let her go, but then she was very symptomatic and was imaged again later in the same day, but at a different hospital. So that's in the morning or close to noon, and then she gets a CTA around 8:20, right? So let me show you that. So now you can see there is this pericardial fluid, and they did this exam. They labeled her as having, as best I could tell, they recognized there was something wrong with the aorta, but they suggested that it was an acute inflammatory aortitis, as best I can tell. She came here with that diagnosis. And you can see the abnormality right there. And then she was admitted. They did some consultation, and surgery said, well, we'll follow her, but we don't know what it is, but they seem to just buy into the notion that it's some kind of inflammatory aortitis. So she was in hospital for a bit, and then they did a repeat CT. Now this is on the 30th. This is the one that I saw. So this is on the 30th, that being on the 28th. And they just ordered non-contrast CT, and I was presented with this to look at. So I'm looking at this non-contrast CT and trying to put everything together. So of course, on the non-contrast CT here, you can see that indeed there is acute IMH in the ascending aorta. And if you look at the pulmonary arteries, you can see it's kind of subtle. So let me see if I can bring it out. But here, there's a little high attenuation focus. And then I don't know if it's going to present really that well to you. So let me try and narrow it, because I want to show you that right here, which corresponded with the pulmonary artery that I showed you before, there is acute hyperattenuating thrombus here in the pulmonary artery. So looking at the whole case now with this non-contrast with hyperattenuating clot, this is acute IMH with extension of hematoma into the aorta, into the pulmonary artery. And it's very much akin to this thing that we showed at the STR about 2 years ago, where you can get involvement of the pulmonary artery, as you can see there with those arrows right there, with blood in the case of an IMH, as you can see over there. So that's what she has for sure. So they didn't do the non-contrast on the one that I showed you, just did the contrast portion at the outside hospital. So why they thought that was some kind of inflammatory aorta, I'm not really sure. But anyway, putting the whole thing together, when I looked at this and then looked at the other ones, I said, there's no doubt this is an acute IMH. This is not any kind of inflammatory aortitis. And then the other interesting thing was, and I'll show you this a second, which was kind of interesting, is that when she had this, let's see if I get this right, when she had the CTA at the other hospital, you can see that she's got renal ischemia on this left side, and it's very focal. So I wondered whether somehow she maybe were flipping emboli somehow related to that aortic pathology and getting the left kidney. And then let me show you one other thing related to that, and then I'm going to show you one other thing too. So tell me what you think of, let me see if I can get this, the appearance of the aorta on the outside exam. So we've got an IMH, and take a look at this here. Sorry to prolong this, but it's really interesting. But I was really intrigued by this intimal irregularity there, and wondered whether there was pathology or a potential breach of intima there. Sort of a, hard to describe, but there's definitely an intimal layer abnormality there, and whether that could be a source of emboli. And then I was really somewhat surprised when I looked at the non-enhanced CT that I looked at, that she has these persistent nephrograms and excretion of contrast via the gallbladder, then I read that she was anuric, so the case became really complicated. But, you know, they did operate on her, and as you can see there, that's the operative report. And they confirmed the aortic dissection. So kind of interesting from several points of view, a lot of pitfalls potentially. Any thoughts about the kidney, by the way? That focal abnormality involving the kidney?
Was there any narrowing of the renal artery or any?
Yeah, there was some irregularity there, which they thought was, they suggested that she had some kind of fibromuscular dysplasia or something there. So there is something wrong there. So if we go here, somewhere here, yeah, I don't quite know what's going on here exactly in relation to the left renal artery, whether it's some other kind of pathology and emboli. I don't really know. I can't explain that.
That looks just like an embolic infarct with the inferior pole being taken out. And then I can't explain why the rest of it looks striated.
Yeah.
But the first study you showed with the what looks like a PE phase where you just have contrast on the right side of the heart, these are the ones that always make me nervous when you have somebody that doesn't have any contrast on the left. You know, like you're showing here. Or is that just, yeah, no, that's a full study, right? Not just a timing bolus or something.
Yeah. No, this is the full study. I don't know why it looks the way it does here.
Well, she's got compromised output. It's got to be what it is. It's either from, you know, reduced ejection fraction, or sometimes when the dissection involves a root. I saw your op note; it didn't involve the aortic valve, but that always scares me. Especially, you can see the ascending aorta is aneurysmal on that image.
Yes. Yeah, it is.
I wonder how much tamponade had at this point too, because she's got quite a bit of pericardial effusion here.
Yeah.
That's why she has such sluggish output.
Right. That would be a reasonable explanation too. But yeah, those types of studies make me nervous, and people don't appreciate, you know, the physiology of it.
Yeah. And I think even here on that CTA on the 28th, that there's probably a little blood in the mediastinum too. You just, you know, the more you look, the more you see the pathology that's present, I think.
So, Howard, putting this all together, I think that irregularity that you showed on the coronal view with
yes.
aortic contrast is probably the source of this intramural hematoma. I think.
Yeah, somehow related to it.
I think there's a little flap there, and that's probably how the blood got into the wall.
Yeah, I think there's an intimal injury there, or a breach, however you want to put it, right there in here. That's related to the salt pathology in some fashion.
And there was
exactly.
There was pericardial effusion, right? Like David said. And is it high attenuation?
Let's see. Yeah, let's see this. I think it is. Let's see if I can just go down here. So
yeah, that definitely looks like it's blood.
Yeah. Yeah, so she had that from the beginning. You know, she presented and had chest pain from acute IMH. That's why she was symptomatic right in the beginning.
I'm sure. I know Brent is on, and I'm sure he's thinking of the same couple of cases that I'm thinking of from when I was at Emory that presented like this with really subtle intramural hematomas and hemopericardium.
Yeah. And you know, now we know why the pulmonary artery wall is what it is.
Yeah.
At that time. There's acute hematoma in it right there. Instructive, huh? Interesting case. I don't know how she's doing, but they did operate on her. Let's see what I have here. I'm going to save that one. Well, we've all kind of seen this before, but it's pretty dramatic. Well, we don't see this very often, at least not in the US, right? So here's a patient with a chest radiograph that looks like that. So we can easily diagnose a very extensive calcified fibrothorax, and with a history of TB, that fits very nicely. I want to ask you about what you think about this. So when I looked at that, everything just fit very nicely. I'm not quite sure why they actually got the CT, but I was intrigued by this. And I don't know if or what that is. Because apparently he may have had a pneumothorax treatment for the TB, and I wondered whether this is suggestive of any one thing. It isn't pure fat like an oleothorax, although I'm not quite sure what an oleothorax would look like if it was very chronic, or whether this is a hematoma or pleural space hematoma because he had a pneumothorax induced for the treatment of it and it filled with blood. I don't quite know what this is up here, but I thought it was just very interesting otherwise. So very extensive calcified fibrothorax with a history of TB and treatment of TB, maybe including something like a pneumothorax. So I don't know if anyone has any ideas about what this might be.
So what they used for oleothorax was beeswax or paraffin, and so that should have lowish attenuation and should be uniform. Yeah. This looks high attenuation. So they did that all extrapleurally. They stayed outside the pleural space. They would peel the parietal pleura away from the inner chest wall, create a pocket, and then fill that with something, including ping pong balls. The lucite plombage was another thing.
Yeah.
So this is probably some, maybe some scarring after that process. But the oleothorax component, if it were still there after all these years, should have low attenuation.
Yeah. Okay. Yeah, I couldn't quite understand that. But I didn't think this was ominous in any particular respect anyway. I thought it was just all part of that.
No, and it's so well defined, it does look as if it's extrapleural.
Yeah, it may well be.
Sharp boundary.
Yeah, like that. So kind of a curiosity in a way, but a very dramatic case, at least for those of us in the US, of calcified fibrothorax. This is just a quick case of, let's see if I can pick out a series of, and I'm not sure if I've seen this before, but it's, I'm sure you guys have, but there's a little calcium here on the endocardial surface of left atrium right there. And there was another tiny focus in the superior portion of the left atrium right there. And when I got a history of several ablations, RF ablations for atrial fibrillation, I thought that's an easy correlation to make. So I'm not sure if I've seen it before or heard of it before. I think I have, but presumably folks maybe have seen calcium after ablations, perhaps like that, or similar to that. Just as a curious.
That's a new one for me. I mean, I think of mitral stenosis with a porcelain left atrium or end-stage renal disease, but I've never seen that with AFib treatment.
It's so focal and so little. I think that's the likely explanation. Like that.
Yeah, because both of the sites are near pulmonary vein ostia.
Kind of, yeah.
What about the upper pulmonary veins? Did they get it too? There's a little calcium anteriorly on the right.
Not sure.
Yeah, we scroll down right at that right superior pulmonary vein was kind of the roof of the left atrium was right in there.
Oh, yeah, right there. Yeah, there.
And then there. Left inferior.
Yeah, by location, I think that's the most likely thing, a bit of scarring and dystrophic calcium, particularly if he's had.
So discrete too. It's so localized. I think you're right.
And and the left atrium otherwise looks normal. The mitral valve looks normal. Yeah. Wow.
Yeah. Exactly.
Those guys are dangerous.
So I think he had more than one for sure. I don't know how many, but more than one, they said. Okay. I can stop there and I can show more if necessary, but otherwise I'll keep mine also for another.
David, do you have any?
I can show 3 quickies.
All right. And Brent, I don't know if you have anything to follow up David with.
So here's a fellow with a cardiac history, including atrial fibrillation, for which he was put on amiodarone, and he became short of breath. And
never mind. Go ahead.
And he had. I'm sorry, how are you talking to me?
Sorry, no. Okay. Your just turned up for me. Go ahead. Sorry.
He developed new pleural effusions, which at this point you can see are small on the right. This was a change from before. I think he also has some pleural effusion on the left in addition to the pleural thickening that was already there. And he got this CT scan, which documents pleural effusion. At this point, it's larger on the right than it was on that radiograph, and just a small amount on the left. they tapped this effusion, and the usual effusion in heart failure, which was their first consideration, although his ejection fraction hadn't changed, the usual consideration is a transudative effusion in the setting of left ventricular failure. But this was an exudate, so they got an exudate out of this. And it turns out that they withdrew his amiodarone, and the pleural effusion resolved, and he was a lot more comfortable. So I was unaware until this case was presented that one of the toxicities of amiodarone is pleural effusion, and it's typically an exudative pleural effusion. And that fits with this guy's history, the fact that his ejection fraction hadn't changed to indicate that he was in worse heart failure as a cause of pleural effusion, and that it was an exudative rather than a transudative pleural effusion. So I don't know whether this is familiar to you guys, but pleural effusion, one of the considerations is amiodarone. He got better after it was withdrawn, but then he was left with his atrial fibrillation problem. Is this familiar?
No, I don't know. I mean, no.
Here's what happens after the amiodarone was withdrawn. You can see that his pleural effusion is gone, and the stuff on the left, I guess, was all just effusion and not actually pleural thickening at all, because it's cleared up dramatically. So put that on your list if it's not already on your list of causes of pleural effusion, especially exudative one.
So that was an exudative one, David? Because I was going to say we've seen a couple of cases of these monoclonal antibodies that cause chylothoraces. I know I've presented at least one. But
yeah, I don't think this guy was getting any antibodies like that, and this was not chylous. It was an exudate. It had two of the light criteria for exudate. Okay, so here's another person who has heart disease, atrial fibrillation, and was put on amiodarone. And this is, his radiograph was somewhat worse now with this basal stuff than the earliest radiograph we had, which was already not clear in the lung bases. So he has this low-grade lung consolidation on both sides, basal predominant, and here it is on CT. So it looks ground glassy with some spared lobules within it. Looks like, potentially an NSIP, or maybe an eosinophilic pneumonia at the bases. Eosinophilic pneumonia acutely can be basal predominant. This isn't particularly peripheral though, so I don't think eosinophilic pneumonia would strike me. Actually, up here it's kind of peripheral, isn't it? So that's the only thing I could sort of dredge up to fit with eosinophilic pneumonia. He was lavaged, and this was 94% eosinophils in the cell count. And his amiodarone was withdrawn, and this cleared up, and it was all gone here on this follow-up radiograph. So almost completely gone at this point. So another case of amiodarone lung toxicity, in this case an eosinophilic kind of reaction, which I don't think is the common reaction, but I think has been reported before. I don't have any literature on this. I did have some literature on pleural effusions, though, derived from amiodarone exposure. So amiodarone is a powerful drug. It's the best antiarrhythmic out there. But it's a little vexed here with these complications. And here's a person who'd had a transplant and developed a lung nodule on the left. And it's a ragged-looking nodule up here. So in our setting, the people who are compromised with transplant will get Aspergillus, Cryptococcus, and nocardia as the usual causes of lung nodules. And we also have to consider lymphoma in the differential diagnosis. So it could be an EBV reactivation in the setting of transplant immune suppression. We have a PET scan that shows that this lesion was hot, and this was biopsied, and this was Cryptococcus. Now, around here, we have to consider Cryptococcus gaddii. It's like the northwest here, and so that's always a consideration, but this was not speciated. We don't know whether this is just ordinary sort of neoformans or Cryptococcus gaddii. But lung nodules around here, Cryptococcus is definitely on our list. Cryptococcus, nocardia, and Aspergillus. And the aspergillus that we see in this setting of transplant immune suppression, solid organ transplant immune suppression, is a much more indolent form than what we see with our bone marrow transplant patients, where it really rips along, evolves very fast. These people can have asymptomatic nodules that are there relatively stable for weeks or months from aspergillus. So it's a much more contained kind of aspergillus. It is invasive aspergillus, but it is nowhere near as aggressive as it is in the bone marrow transplant population. So cryptococcus in this solid organ transplant patient.
David, was the diagnosis made by CT guided biopsy or endobronchial?
I think it was
biopsy?
CT guided.
Yeah.
I can check. Does that help? I mean, is that it?
I was just curious, and of course, like the PET was done after the CT, I assume, because it really doesn't add anything, in my mind.
Yeah, it doesn't, but I wasn't going to throw it out.
Yeah.
So there is a problem with lavage, trying to make the diagnosis of an invasive fungus like aspergillus. If the organisms are really tissue invasive, they are sometimes not that available to be washed out on a lavage. So we've seen a number of cases of negative lavage but positive needle biopsies in the setting of invasive aspergillus, because the organisms that are in the tissue, just may not be in the air spaces, and the lavage fluid may not even get near them. The same thing's true for mucor. We had a case of zygomyces a couple of weeks ago that was negative on lavage but was diagnosed on needle biopsy. So if fungus is a strong suspicion, don't be satisfied with lavage results if they're negative.
Yeah, we've been doing a lot more biopsies, CT-guided biopsy and FNA for suspected fungal infection. And our yields, we had published this like a year ago, the yield wasn't great. When you suspect infection, we were less than, I think, like 35%, somewhere 30-35%, but still, that's enough for the clinicians to want to do it, just to try and speciate and know what treatment they need.
Right. Okay, those are my cases.
Okay. Great. See, I'm going to show a few here. I guess Brent is not here. Do you guys see my screen?
Yes.
Okay. I've got a few. Start with this one. This is more iatrogeny. Oh man, let me make sure this is the right one. I think it is. Yeah, I guess I don't have the original CT. This lady had an outside CT. She was kind of a disaster, as you can see here. Oh no, I don't have let's see. Yeah, no, I don't have the original CT. But anyway, she's pregnant at an outside hospital, ended up with like a bedside C-section or something that just sounded kind of disastrous. And to make a long story short, ended up intubated a couple of days after this study. This was on the 22nd. Here, by the 25th, you can see she's intubated. She's got a lot of subcutaneous emphysema. They thought she had a pneumothorax on the right. It turns out she didn't. They did a needle decompression on the right, straight into her lung, as you'll see on the CT. But then she did end up with a pneumothorax on the left, which they placed a chest tube for. And so I don't know. She wasn't getting better, so they did this CT. And, people spend a lot of time discussing the lungs and trying to figure out what was going on with her lungs. But like I say with ICU radiographs, I think this leads more evidence to the fact that the lungs are the least important part of ICU CTs too. So here's the chest tube on the right going straight into the lung parenchyma surrounded by hemorrhage. But what wasn't noticed at first overnight was the fact that her trachea has this, focal big time bulge in the membranous portion of it. So I saw this in the morning. And of course, her trachea was normal caliber on the prior CT before she was intubated. And so this, call up the surgeon. They went to the OR that day and found that she had a 3-centimeter tear in her trachea presumably from the balloon. And you can see nicely here on the sagittal view that that it just looks like almost like what a pseudoaneurysm would look like in a vessel, just with the focal outpouching here, right at the level where you would suspect the balloon. I think this is the first one I've seen, that I could pretty much assuredly attribute to the balloon. I don't know. The limited reading I've done, yes, this can happen during the intubation process too, but one of the mechanisms I read was overinflation of the balloon, especially if there's like sudden coughing or movement that causes the endotracheal tube to dislodge or move, which in her case it may have, because if you look at the original radiograph when she was intubated versus the later ones, I think it's in a slightly different location. It's further down towards the carina, as you can see on this image. So, like I said, this one was proven, and they went in and repaired her trachea. And what's interesting too is that her pneumomediastinum had improved. This was a couple of days before the CT was done, so I don't know if the balloon was actually sealing off the big hole that was causing the pneumomediastinum or not, but I thought it was a good example and a scary finding.
Travis, do you think you're actually seeing the bulge in the air column on that last radiograph that you had up?
Oh yeah, on this one, yeah, right here, yeah, probably. Yeah, you're exactly right. Along the right aspect of it.
Yeah, right posterior.
Yeah. So, I don't know. Have you guys seen this before from a balloon on CT? I mean, we've seen it discussed on radiographs before, but
not sure that I have.
Do you think on that CT was the balloon was inflated there, right?
Yeah.
Okay.
Yeah, if you window it, you can kind of, it looked like at least here maybe it's like a little portion of the balloon membrane. I don't know, but it was definitely inflated here.
Got it.
It's not easy.
I've seen small injuries from balloons, not a massive hole like this looks like.
Yeah, and it was a 3.5 centimeter tear, and it makes sense that it would be posteriorly in the muscular or membranous portion of the trachea.
Yeah, never seen that.
I'll bet you it was from the placement itself, from the sharp tip of that endotracheal tube going down.
Maybe. Yeah, I found one case series of 3 cases that describe different mechanisms, both of which were included.
Got it.
This is a really cool case that I just recently saw, and apparently my talking got Siri to start to query that.
I was about to say, sounds like you're driving somewhere.
No, it was just Siri in the background. So this was kind of cool. This guy presented, I'm going to withhold his history for the moment, but he presented with this mass, and you can see it's intermediate attenuation and some chunky areas of calcification. And this was a year ago or so. He's also got some peculiar pleural thickening on that side. He's got another something back here. What's really interesting is this stuff surrounding his pancreas. As you can see, the soft tissue infiltrating in the retroperitoneum. It's kind of in the mesentery too. To a little extent, it surrounds the kidneys as well. So this is what this guy had, all of these findings. This retroperitoneal mass and his mediastinal, if you want to call this cardiophrenic angle, were both biopsied. Any guesses on what you think this is?
ACH.
I'm going to guess Erdem Chester.
So he has a history of Waldenstrom's macroglobulinemia for 20 years, since the early 90s. And so these were all amyloidomas. And this is all amyloid deposition. I have the path. So when they biopsied this, B cell population and Congo red stains were positive. Then they did the right pararenal mass, also amyloid deposits.
Wow.
Yeah, I thought that was really interesting. Now, I know very little about Waldenstrom's macroglobulinemia other than it's similar to multiple myeloma. I think it just has, it's considered a neoplasm with different clones of lymphocytes in them that will, and B cells that will produce protein and amyloid. I don't know, Howard, you might, or somebody else may know more about it than I do, but it's certainly one that can cause this. And there's a little bit of activity.
Yeah, I wouldn't have guessed that.
So was that big anterior cardiophrenic angle mass lighting up on the PET, or was it?
Yeah, it was. Here, I'll put up the PET side by side with its CT correlate. It has some low level metabolic activity in it, right in here. I mean, it's not lighting up. It's actually not even really much bigger than baseline. But the stuff in the retroperitoneum, similar too.
Huh.
So, yeah. So I just
Amyloid deposits. Wow.
Yeah, I thought that was a cool one because I know others have shown amyloidomas before, but sometimes they seem to be more discrete and more calcification, but
it's actually ossification often.
is it ossification when you see it in the lungs too with amyloid?
Yeah.
Okay.
Bone.
All right. Now I'm going to show. Let's see. I think this is. No, I'm going to show this other one first. Let's see. So this is an interesting one, and this is a patient who has stage 4 colon cancer, and this was from 2013, so a few years ago. And I think this was a metastasis at the time, and I don't remember. It's not really pertinent to this, but anyway, he looks okay in 2013. He's been around, well, he's got this. He did okay after this until 2016. He ended up with a different treatment starting at some point during 2016, and he presented with this back in October to an outside hospital. And so he's got bilateral foci of ground glass consolidation. It's got this perilobular distribution. It's fairly symmetric. And in the absence of signs of infection, certainly looks like an organizing pneumonia, which you would think would be due to a drug reaction. And I don't know what they did in terms of changing his drugs or anything, but he certainly progressed, and now it looks like it's still a good look for an organizing pneumonia. This is a couple months later. And it was back in March that he was finally referred to our ILD clinic. And you can see that he's still on the drugs. It's evolved a little bit more, still looks good for an organizing pneumonia pattern. And so we thought this was going to be a drug reaction from what he was on, but the ILD specialist that saw him did a nice thorough exam and noticed what he thought were mechanics hands, as I will show you here. And so as a result, he sent off a myositis panel, and it actually came back as PL12 positive, so one of the anti-synthetase antibodies. And so, right now we're not sure, but we're thinking that this is probably due to an anti-synthetase syndrome that just manifests itself over the last few months, especially given the other physical exam findings, rather than a drug reaction. And it has the typical distribution. It's more mid and lower lung predominant, certainly an organizing pneumonia, maybe a little bit of NSIP if they had biopsied it earlier would be seen in here. But I just thought this was really interesting, and I don't know if it's the treatment that kind of unmasked this or if he just happened to develop it, because as you can see, he's middle-aged. So I thought that one was kind of cool.
Wow.
So
what is mechanics hands?
The mechanics hands, I don't know. You have to Google a picture of it, but you get like these coarse, roughened hands that is a skin manifestation of connective tissue disease and typical of antisynthetase syndrome. They'll also do like capillary microscopy, and I don't remember the exact term, looking at the capillaries in the hands. It can also detect skin changes, as you can see with scleroderma or with in antisynthetase syndrome in this case. So that's one of the buzzwords for antisynthetase, but I think you can see it in scleroderma and other connective tissue diseases as well.
Yeah. It's one of the classic associations, along with another skin lesion called Groton's papules. Those two things always ring bells for inequality.
Yeah. And I guess I just pasted some of the note in here that they thought it probably wasn't due to his chemotherapy, just because I guess they withheld his treatment and it didn't get better. So now I showed that one so I can show this one, and I regret that I wasn't on last week, because reading David's cases that he sent out and seeing his rheumatoid arthritis case with the lower lobe, essentially a honeycomb mimic, and I missed the discussion. But I think it's similar to this case, and this is not an ILD CT. This is from an outside hospital, and it's thick section. But this is another patient who's in his 60s, and you can see, at least at first glance, looks like this is just extreme honeycombing in the lower lobes. And these are the ones, and I know, David, I think Jeff had tried to coin it as champagne lung or something, where you have all of these cysts that kind of mimic honeycombing. But if you see here, it's not just traction, because you can follow the airways out pretty far into these areas, and it looks like the airways are just surrounded with cysts. And the other thing that isn't great for a classic UIP IPF is the fact that remainder of the lung is completely normal. There's no reticulation in the other areas at all. So this was one though, and these are the ones we struggle with, and we've seen a lot of them. And these are the ones I like to call the definitely not possible UIP pattern, meaning they're either a definite UIP or they're inconsistent with UIP if you're using the ATS guidelines. Because I don't know, and we go back and forth on these, but this is one where we weren't sure. He had been diagnosed presumptively at an outside hospital with UIP, IPF. And you can see from our note, we kind of, we, at our discussion, we said, maybe these are cysts rather than honeycombing. He didn't have any connective tissue disease symptoms, but they sent off his panel and it just came back. And he has a SSA that's through the roof, so it could be Sjogren's, but he also has anti-Jo1. So he may have antisynthetase syndrome as well. So this may be that these are just, cysts as a result of connective tissue disease rather than, UIP honeycombing. So David, I don't know what your discussion was last week, but I think looking at the case, it's similar to this, although yours was more dramatic.
Yeah, it is very similar. The other situation which I'd seen this really floridly in upper lungs along fissures was in burned out sarcoid. Not with a lot of not a lot of distortion. It wasn't just bullae and scarred up lung, but it was just these rows of these thin-walled holes along pleural surfaces and stuff like that, upper lung predominant. Yeah. So you wouldn't want to call it a UIP. And Rod Schmidt, our pathologist, was looking at the rheumatoid case that I showed last week, and he said that these thin-walled cysts are actually lined by a columnar, ciliated epithelium. So he thinks that these are derived from airways. So,
but honeycombing cysts are derived from airways.
Yeah,
but yeah, I don't think they have a ciliated lining. They can.
They can. Yeah, we see it. We see it. Not. It depends on who you talk to. I mean, the pathologists have as much disagreement about this as we do, even though that no one talks about that. But yes, I have seen it with columnar epithelium that a very good pulmonary pathologist calls honeycombing.
So Seth, I'm curious on your take on this too, because I see cases like this, and this isn't. Maybe this is honeycombing and UIP, but the other areas, the fact that they're so strikingly normal, and the fact that he has now a connective tissue disease, which certainly doesn't mean he can't have a UIP, but it's just weird.
It is weird. It would be very interesting to see what the pathologist says on this, and because so often, what they call honeycombing isn't what we call honeycombing, sure, as we know. And it would be interesting to see if the microscopic features they see is consistent with UIP in their book. I would have called this personally. I don't see this infrequently where you see this, what looks like honeycombing, and the airways are completely normal, and you don't know what to do because, there's alveolar collapse and there's airway dilation because of that. In the absence of that, do you call it UIP or honeycombing, even if it looks so classic? And we struggle with this too, and I don't know. I'd be really curious to see if you gave 5 pathologists what they would call it.
Well, I've collected. I don't have path on this one. I have path on other ones similar to this and similar to the one David showed last week.
What do they call them?
Well, our pathologist, and we've discussed this. Oftentimes, he sees stuff that looks like follicular bronchiolitis and LIP and other things that aren't, and he doesn't call them honeycombing. But then again, he talks with us, and we may bias him by saying, well, this is one of those weird ones that it may be cysts.
Well, follicular bronchiolitis and honeycombing, they look nothing. They really should not look anything alike. If you have follicular bronchiolitis, you could potentially, get faked out by lymphoid follicles, but follicular bronchiolitis is a pretty striking airway center process.
Or you may have both, though. I think that they'll look more for airway-centered, follicles and lymphoid aggregates and things that may steer them away from a UIP. So,
if you get enough of these, you should, if everyone does, you should publish it. It's really interesting, and I see this all the time, and I don't know what to do.
Yeah.
I think we should see if we can collect these, and then because ultimately, I think we were right in the sense that it prompted a more in-depth connective tissue disease panel than would normally be sent off, because normally
and they're going to biopsy them. hopefully, because it's not.
Yeah. Well, they may biopsy
Instead
him,
of just-
or they may. Yeah. I mean, they're now talking about starting him on immunotherapy for connective tissue disease rather than starting him on pirfenidone or nintedanib.
Right. So our case last week, our pathologist said this is not UIP.
Yeah.
Okay. Well, that's great. And that's the most important thing. If they say it's not.
Part of it was that there was not very much fibrosis. So you've got a bunch of holes in the lung, but the holes in UIP should be within a matrix of fibrosis, and that was lacking. There wasn't much fibrosis, and that's why the cyst walls were so clean and thin. So I agree, guys. We ought to combine these cases and put it out there, because when people look at this, they're going to say, okay, that's UIP, end of story, stop the workup. So we really need to get the message out that look further when you have this non-fibrotic set of holes.
And I know Brent has a few of these cases too.
Yeah.
So
one place to look is the burned out sarcoids.
Yeah.
Dave, is there any way you can get a path slide and show it to me, and I can send it to a pathologist just to see what they say? Like just a, not even a like an Apereo picture. Do they do that there?
I'm trying to do that. I'm waiting to get some actual pictures from the pathologist. Okay. I hope maybe tomorrow or next week.
Yeah, and if you can send it to me, I'll show it to our pulmonary pathologist too. And
just to see what they get.
Curiosity, yeah. Right. Because it would be interesting to have path and imaging, maybe show it blind to a bunch of different radiologists and a bunch of pathologists. Well, first of all, just collect the data that we have, but then also see if you get some sort of agreement or disagreement amongst people.
Well, I guarantee 99.9% of radiologists would call this UIP, and I would be tempted to as well, because it's just. Yeah.
And I called all of these UIP when I was at Emory until I got out here, and Rick and Brett are much more keen on this. They're like, because they have path on a lot of these, and when they go to explant, then it comes back and it's not UIP, that it's something else.
Yeah.
So
that's fascinating. Yeah, it's cool.
But yeah, so this was another antisynthetase syndrome, presumably, and the distribution certainly fits. It's this extreme basilar predominance. So just a more pronounced fibrotic pattern. So, all right.
That's cool.
Well,
thanks guys.
Thank you, guys, and we'll see you next week.
So it's next week after the meeting? The meeting starts this weekend, is that right?
No, next week.
Next week.
Next week, you guys are around?
Yep.
Okay, great.
Yeah, take care.
Right. Take care.
Bye-bye.
Thanks, everyone.